Okay, thank you so much. It's a pleasure and welcome everybody. It's wonderful to organize this meeting. So far it's going great and I'm learning quite a bit. So this is the lecture. So the bioprosthetic failure is not that complex, but maybe the decision making is complex. So this is a 47-year-old lady without cardiovascular risk factors. As you can see, the age is getting, patients come young now with bicuspid aortic valve, with aortic stenosis and aortic regurgitation with an ascending aortic aneurysm. About 10 years ago, had surgery with a bioprosthetic 29 millimeter perimount magna and a repair of the ascending aneurysm with a graft size 30. Now she comes back with shortness of breath and exertions and dizziness. Her pro-BNP is slightly elevated, and obviously she has a low predicted risk of mortality by the STS score. As you can see, here is the envelope with the pressures. She has severe prosthetic aortic stenosis with preserved ejection fraction. These are the CT measures, and these are her hemodynamics. The coronaries were obviously normal in a young patient. So I would like to ask, maybe somebody can answer, or maybe we can talk here in the panel. I have only 5 minutes, so what's the best strategy for this patient? So this is where the heart team becomes handy. And then when I saw this patient, I initially referred the patient for SAVR. So is the best strategy to reduce SAVR? Now, is it to do TAVR? There may be lower risk of mechanical complications than with reduced SAVR, but there's a higher risk of an elevated gradient, patient-prosthesis mismatch. There's a possibility of valve thrombosis, malpositioning of the transcatheter valve, and then if we choose one, do we choose a self-expanding or a balloon expandable if this is the route we're going to go? Any comments?
The big thing here is 47 years of age, and at 37, she got a bioprosthesis. So we are assuming a normal lifespan of 80, 85 years. This has multiple procedures down the road here. So a case could also be made for doing a redo with an Onyx-type mechanical valve at 47, assuming she's done with childbearing and she's postmenopausal now, where bleeding is not an issue. Alternatively, another surgical AVR with the Inspiris type valve, which can be expandable, where at least you can guarantee at least 2 valve-in-valve towers. Something along the lines is what I would be thinking about.
Yeah, so Dr. Romagna just walked in the room. So we made the decisions here with the heart team, and Dr. Romagna and I led the discussions, and the patient absolutely refused to have a new surgery. So the subsequent discussion was what to do, a self-expanding or a balloon expandable. Self-expanding would probably give you a better hemodynamic profile regardless of the valve. You can do an Avitor, the leaflets open better, or a core valve that has supraannular better profile. The thing is that this patient had a 29 prosthesis, so it doesn't matter that much. So what matters is that she's going to have a new intervention in a few years. So if she has a new intervention, and let's say that she's going to have a SAVR with a TAVR SAVR explant, so what's going to make that surgery easier is what made us choose for a balloon expandable valve. So as you see, the case per se technically was not complex. So we put a 29 millimeter sapien. So there was a little bit of perivalvular leak after we deployed. So we post-dilated with an additional 2 cc's in the balloon. And this is a final result. There was no residual AI, so it's a perfect placement. A year later, the patient came back. She has a residual mean gradient of 6. She's doing very well, but we have to look at future procedures with her, and that's where the decisions are complex, and I think this sets the stage for the discussions we're going to have in this panel. So was TAVR the right thing to do? What do you think?
Well, I think she made the decision for you, right?
Yeah.
She refused surgery, and I agree with what Melinda said. It would have been nice if you could have persuaded her. I think that a reduced surgical procedure with the mechanical valve, especially in light of the newer data that suggests that mechanical valves lower risk of mortality, not necessarily in a reduced scenario.
Yeah. I mean,
So,
she will still be in good shape when she goes for the next procedure in her 60s. And so, and having a SAVR at that age will probably reset the clock and allow her to go for another round of two of subsequent procedures.
And the other thing is, when the patients decide, I am vehemently against doing the open procedure, do they recognize that the mortality data related to a TAVR explant in 2025 is not really good? And that is one of the things that we will talk about. Right now, we are in the interest of time, but we'll have a panel discussion about that.
But let me tell you, if Juan Umaña could not convince the patient, nobody can. Well, thank you so much, and I look forward for the panel discussions.